Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center reporting for the week of March 7th, 2022. Masking requirements will be lifted this week in most schools across the state, so I will talk today about what this might mean after providing a brief local update. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of this People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Here in Alameda County, our total cases over the previous 14 days continue to come down nicely. They are still higher than any baseline we'd like to see. We'd like to see them get nice and low before we potentially may be heading into a summertime surge, but for right now, they are continuing to head in the right direction. Hospitalizations are also decreasing. We now have 102 people in the hospital with COVID-19 in Alameda County. 1,777 people in Alameda County have lost their lives to COVID-19. This is an increase of 43 compared to what I reported last week, and 19 of those individuals are reportedly from Oakland. And in our skilled nursing facilities, we've had an increase of 3 deaths according to the county dashboard. So the total there is now 323 individuals from the skilled nursing facilities who have passed away due to COVID-19. And statewide, we are still seeing this major discrepancy here between the unvaccinated and the vaccinated, as well as the vaccinated and boosted. Those who are unvaccinated are more than 17 times more likely to die from COVID-19 than those who are fully vaccinated and boosted. And we are still seeing that those who are boosted, although you can see that the boosted and vaccinated are a much lower risk than the unvaccinated, the boosted are still quite a bit more protected and actually almost half of the risk of dying compared to those who are not boosted. And nationwide, we're still, for the full days that are reported, at about 1,800 people dying per day of COVID-19. So still, it is heading in the right direction, which is good news. We know that it is our most lagging indicator, but still quite high in terms of losing more than 1,500 people each day from COVID-19. And so still have a ways to go there. And in terms of the variant proportions that we've talked about, the BA2 variant, subvariant of Omicron, although it is still, a relatively small percentage of the overall specimens that are being sequenced, you can see that they're more than doubling kind of each week. And so that is a little bit concerning. It still remains to be seen how this is going to really impact our population, particularly given how much Omicron exposure and how much Omicron infection we've had so far. It's really not clear what this is going to do, but this is something that we have to really keep a close eye on because this particular subvariant does look to be evading the monoclonal antibodies that are working against Omicron. And also, I think it remains to be seen how our vaccines are going to hold up against this. And remember that this is sort of increasing at a time when our protection from vaccines may be, or from prior infection may be starting to decrease. And so this is these are all the moving targets that we kind of want to just make sure that we're keeping an eye on. So the state has indicated that they will be transitioning from a requirement for masking in the school setting to what they're calling a strong recommendation. So it is not that the state has said that masks are no longer needed. They are strongly recommending them, but they are moving away from a requirement. And what Dr. Ghali at the state has said is that it feels like time. So this is not strictly a disease transmission piece of guidance. This is clearly something that is taking into account a number of different factors. But I will point out that the American Academy of Pediatrics, which is the association that really looks out for our children and is looking from the clinical perspective, is still saying, and I will quote here the AAP official guidance: all students older than 2 years old and all school staff should wear well-fitting face masks at school unless medical or developmental conditions prohibit use, regardless of vaccination status. The AAP currently recommends universal masking in school with an emphasis on indoor masking. And the AAP president, much like the American Medical Association president, who I quoted last week, have basically come out and affirmed that they still believe that we should be wearing masks. And so, where are we in terms of pediatrics and COVID 19? So, I have to say that it has been very, very difficult, really, in this entire time to get good, solid, consistent data on pediatrics and COVID 19. Even the American Academy of Pediatrics, which has a very comprehensive data reporting, they do a weekly data report. The link is in the post. And even with them, all states have not been reporting this entire time, and states are not reporting evenly, and they report things a little bit differently, and some are not reporting at all. So with 46 states reporting, we have had 914 pediatric deaths so far. And the challenge that we're having now is that this is actually increasing. So in 2022, so far, we have lost at least 179 children to COVID-19. This is about 3 children per day. And again, about 179 just since the beginning of 2022. And for comparison's sake, since everyone wants to always compare to the flu, we have had 1 pediatric death. So 1 pediatric death from flu, 179 from SARS-CoV-2. And so what the concern is that we are not going in the right direction here with our children. And this, mind you, is before any lifting of mask mandates, although we know that some areas have lifted them some time ago. But where we are now in terms of cumulative hospitalizations for pediatrics is at about 40,000 hospitalizations. So 40,000 children who've had to go to the hospital with SARS-CoV-2. So is very significant. And again, what's concerning here is that while early on the percentage of pediatric hospitalizations compared to overall was less than 1%, it was usually 0.7%, 0.8%. It's just been creeping up and up and up. So as we've gotten our elders protected and adults are now mostly vaccinated, especially in the older age groups, we're just seeing this impact start to affect younger and younger age groups. And so now pediatric hospitalizations are 3.2% of the overall. So again, even though numbers are relatively small, heading in the wrong direction. The other concern is our disparities, and we are already seeing some very shameful disparities as it relates to COVID-19, and COVID-19 mortality in children is no exception. So looking here at the cumulative COVID-19 mortality in children under 19, you can see here that African American children are 2.5 times more likely to have died from SARS-CoV-2 than white children. And Latino children about 1.7 times more likely. And so these are disparities that are not completely understood. We understand some parts of it, but there are some pieces that we don't clearly understand yet. There's actually many things about SARS-CoV-2 in general, but in particular with children that we don't understand. I'm going to talk a little bit more about those in a moment. But this disparity is very concerning because when we start to lift universal protections, we expect disparities to actually increase. So increasing from here, we're not off to a good start to be increasing from. When we look at the geographic distribution, we're also seeing some differences where we are having a greater concentration of mortality across the South. And looking here at total hospitalizations right now, we still have over 1,300 children that are hospitalized right now with SARS-CoV-2. And again, unfortunately, these data sets are not complete. These last 3 tables that I've shown you are from covidkidproject.org. Link is in the post. Very impressive amount of data that they've been able to put together into these charts. But still they note on their website that it is not 100% reporting, because we really just don't have a great unified system for gathering this data. And that's something that we really need to keep an eye on, because as we start to lift protections, we really have to have a good handle on our data. We have to be warned ahead of time when things are happening, or as soon as possible when things are happening or changing. And when things are going in the wrong direction with any group, as we're sort of seeing here with kids, then certainly we need to have good, robust, and reliable data sources. So this data source regarding hospitalization is including inpatient beds, also the newborn ICU and nursery, and there was 6,021 hospitals which are reporting in this data set. They report to the United States Department of Health and Human Services. We are hopeful that hospitalization data will continue to improve, since those are some metrics that, as I reported last week, that we are going to be relying upon more heavily, or the CDC is relying upon more heavily, is about hospital capacity. So that means we really got to get better at being able to assess how we're doing in terms of hospitalizations in general, but also for pediatrics. And the highest concentration of pediatric deaths are actually in the two extremes of the ages for pediatrics, in the under 1-year-olds and in the 19-year-olds. So when we look by year, by age, by year, then the two highest mortality rates are in under 1 and in 19 years old. Now we know that death is not the only thing we're concerned about. Following the initial COVID-19 illness, there is a condition called multisystem inflammatory syndrome in children, or MIS-C, and we've done some more in-depth discussions about what MIS-C is. But certainly if your child catches COVID, then after that initial period, we want to be keeping a close eye on them, because they can have this very serious multi-inflammatory system condition, and basically can affect, as the name indicates, any organ in the body. It is an inflammatory condition, and it does cause children to have to go to the hospital, sometimes the ICU. We've had 7,459 MIS-C cases that have been reported nationally, and 63 of those children have died. And we don't understand everything about MIS-C. We really don't know why some people get it and some people don't. We don't know why 58% of the children who are getting MIS-C are either African American or Latino descent. It's a bit of a mystery, and that is very concerning, because we need to understand more about this complication. And these deaths are not necessarily counted as COVID-19, because they're kind of a later effect of COVID-19. And the majority of the MIS-C cases are happening in the 5 to 11 age group. And also, it's worth pointing out that we can see long COVID in children. It can affect multiple organs, both in adults and children. It's kind of a busy graphic here, but basically it is showing that the SARS-CoV-2 really, it can attach to the ACE2 receptors, which I know we've heard about before. That is what the SARS-CoV-2 has a great affinity for. And it can attach to these receptors really to gain entry into the cells of many of our organs. And once it gets into those organs, the virus can basically wreak havoc and cause damage and lead to a number of symptoms, some of them long lasting, as you can see here, and can really occur in just about any organ. And we don't understand all of the mechanisms and the reasons why this is happening, or how to prevent it from happening. And there's really, frankly, more that we don't know about long COVID than we do know, it seems like. There's a lot of study underway. I will dedicate a briefing to this topic in the near future. But the study that I think is probably cited the most, although really, honestly, they're all over the map, but the one that seems to be the most robust is showing about a 1 in 7 chance that a child will still have symptoms 15 weeks after infection. And so part of the problem with long COVID is we need to establish kind of this universal definition and a universal way of reporting it. But if we go with the 1 in 7, we've had 12.7 million child cases of COVID-19 that we know of. So 12.7 million cases of COVID reported. So we're talking about the potential for a couple of million children already to be suffering with long COVID. Don't know yet if that's the right number, the right proportion, but at any rate, when we don't know things, that's usually when we want to err a little bit on the side of caution and not expose children to the potential of this, because although we worry about long COVID and chronic conditions after infection with anyone, we worry about this with adults too. But when it comes to our children, we're talking about long lives ahead of them and a number of years that their quality of life can be affected. And we're certainly seeing that there are cases of neuropsychiatric issues happening after COVID, but also respiratory, cardiac, fatigue, and a number of sort of late symptoms that linger on for some time. So, as I mentioned, I don't think we know exactly how common long COVID is in children or in general, really, yet at this point. We don't understand the risk factors for developing long COVID. It does not necessarily appear to be correlated to the severity of the initial infection. So we're really perplexed about that. We don't understand kind of the mechanism. What is underlying long COVID? Why is it happening? And what are the actual mechanisms? Is it directly the virus, or is it or could it be some just kind of effects such as just the trauma or the stress of having been hospitalized? We really don't know. We don't know if we can prevent it. We haven't figured that out yet, how to prevent it. Although there are some studies that suggest that the vaccination is associated with a lower risk, but we have not seen that consistently across the board. It seems like it is people who've been vaccinated, of course, we know are less likely to catch COVID-19. And so just for that reason, they'd be less likely to then, have it and then have to have long COVID. But it does seem to be reducing at least some of the long COVID associated symptoms. But this would be one argument, I think, for vaccinating our children is not only to prevent catching it, not only to prevent hospitalization, not only to prevent death, but also to prevent or reduce the risk of long COVID. We also don't know how to treat long COVID completely. A lot of it has been symptomatic treatment at this time. Until we learn more about the mechanism, it's going to be very difficult to know how it is that we should treat it. So even though most of the time children will recover well with SARS-CoV-2, we are still losing children to SARS-CoV-2. Children are still being hospitalized with SARS-CoV-2. Children are still having MIS-C, multi-system inflammatory condition, and being hospitalized from that or dying from that. And children are still catching long COVID. So these are all the realities that we're grappling with. Now, when we look at the vaccination rate across Alameda County, you can see that in the 5 to 11 age group is very far behind in terms of vaccination. We're only at 58% of those 5 to 11 being fully vaccinated. So this is concerning, just lagging so far behind. The next groups are all in the 80 percentile. So granted that it came out later than the vaccines for the other age groups. However, we really had hoped to be further along in this age group than we are now. We understand that parents are naturally going to have a lot of questions and concerns about anything new for their children. But at this point, we are seeing a really, really excellent safety profile with the vaccine for the 5 to 11 age group. We're still getting data about how effective or how long the effectiveness will be, or will children from 5 to 11 need the booster. So I think we still need some more data. We need some more conclusive data to land there. But nonetheless, we know that this is offering protection from the most severe outcomes. And at this point in time, this is concerning to me that we are going to now lift mask mandates in our elementary schools and middle schools and high schools. But I feel less worried if we're in the 82, 85% vaccination rate versus the 58% vaccination rate. And so we know that our children, some of our children will be vulnerable, and certainly those under 5 are all by definition completely unvaccinated. So, and as I mentioned, some of the highest mortality rates are in babies, little ones. And so we know that oftentimes we might have a child in school, we might have a baby at home. And so we just want to be considering our own situation, our own home situation, who it is that we're going around, who it is that we might be exposing. And when you look at this vaccination rate for 5 to 11-year-olds, that really does give me pause and make me concerned about lifting any mask mandates. Now, at this point in time, we still have not heard from every school district. We have not heard from Oakland Unified School District as to whether they are going to align with the state and the county, who have essentially said that they're strongly recommending masks in school but not requiring them. When you look at Oakland Unified School District vaccination status, and this is only for 12 and up, the darker red areas, and this is pretty delayed data here, so I'd love to see some updated data because this is December 1st, 2021, so it's a little old now. It also doesn't include anyone under 12, which really, I would love to see OUSD please update this, especially if you're going to remove protections. We have to have a better handle on our data. And I'm saying this to everyone across the board, United States, state, everywhere. We need a better handle on our data. If we're going to start removing universal protections and moving this into an individual realm where we're going to have to make individual decisions, then we need the data upon which to make our individual decisions. So would love to see this updated, but nonetheless, you can see now that the same areas tend to light up. Same areas of East Oakland, a little bit in West Oakland that have the most unvaccinated students. These are the same areas that have had the highest case rates and have the lowest overall vaccination rates. So what this also means is that a student who is going to school in these areas will have higher potential exposure rates. And if they bring it home, the likelihood that there are vulnerable people within the household. These are also the areas that tend to have more crowded households, that tend to utilize more public transportation, that tend to have a higher burden of chronic disease, and have a higher proportion of essential workers. And so all of that, to me, amounts to the fact that lifting of universal protections will have a disparate impact, meaning that it will affect the communities that have been the most hardest hit already, the hardest. And so I think it's not okay to say that it's fine for kids to just catch COVID and that cases are not a problem. Cases are a problem. Catching COVID is a problem because anytime you have more cases, then you have more hospitalizations and you have more deaths. And anytime you have more mixing of people, especially without masks on, then you're going to have more cases. And when you have more cases in school, that also means more missed days of school. It means potentially the teachers and the staff also being exposed. Teachers being out also means no instruction for those days. And then ultimately, it also means more people with symptoms, potentially with long COVID. And all of these things will also lead to learning loss. So it has been a very I think, political topic, and it does seem that many of the decisions that are being made are in that realm of political response. Because as I mentioned, our main American Academy of Pediatrics, our American Medical Association are stating that from a disease transmission standpoint, now this is not about all the other factors, but just from a disease transmission standpoint, that this is not the time to remove masks. Having said that, it appears inevitable that that is where it's going. So that being the case, I think it is really incumbent upon each of us to assess our own situation, our own local context. We have dashboards, we have maps, we can look at our own case rates, even down to our zip codes. We can look at vaccination rates down to the census tracts on the Alameda County dashboard. And you can see there the disparities that already exist. And once we remove these protections, those disparities will likely widen. So when we think about COVID and children, Here's a little recap of where I think we are. Remember, we have no treatment for anyone under 12 years old. We have no vaccine for anyone under 5 years old. We have low vaccination rates for those 5 to 11. If your child is going to be going to school and being around others who are not masked, the best protection that they have is the vaccine. Then we also know that we will have a higher exposure for those who use public transportation, those in crowded schools, those in crowded households, etc. Also, higher exposure for those in schools with poor infrastructure. Well, what do I mean by that? Some schools have a wonderful HVAC system with some HEPA filters and they can open their windows if they need to. Other schools have windows that don't open. They are relying on a in-class unit and they do not have good ventilation in general. And so those with poor air exchange are going to have higher exposure rates. So again, you can see how these disparities manifest themselves and how we expect them to. And of course, uneven vaccination and booster uptake. And so again, that means that we will likely have pockets where there are more cases and more outbreaks, especially as we head into potential summer surge and the winter surge after that. And maybe I'll just take this moment to say that I have been a big proponent of longer winter break. I think that many people were actually advocating for that this past winter. I said the same the year before because we know that in general, a lot of respiratory illnesses are transmitted during that time. But with such a devastating winter surge that we had this past winter here, it really probably would have reduced the amount of transmission and the amount of cases had we lengthened the winter break. So it is an idea for administrators and leaders to consider to have a longer winter break. We saw that the community college district was out most of January, and surely, that can be a real savings grace if you don't have that mixing happening during the time of the highest case rates and the highest transmission. So I think something for policymakers to consider. So I think what we are looking at now is we're going to be waiting to see what the individual districts decide to do. I know that myself and many of my colleagues, community physicians within Oakland who care for our community, are hopeful that OUSD will maintain the masking guidelines. We also do understand the tremendous pressure that is occurring. We also know that that is not related to the reality on the ground of virus transmission, of what we can expect in terms of future surges and what we can expect in terms of widening disparities from here. And so oftentimes our universal protections are really to protect the most vulnerable among us. I would be remiss to not mention those students who may themselves be immunocompromised, where their mask may not be enough to only protect them. Also, those who live in households with people who are immunocompromised. And remember that if you are under 12, you're not eligible for any treatments, including the pre-exposure prophylaxis, Evusheld, that I've mentioned several times now, that anyone who's eligible, who's immune compromised, can get in order to protect themselves for 6 months. But children are not eligible for this. So I don't know whether going forward there will be optional masked classrooms, for example, for those who would prefer to wear a mask or for those who need that type of accommodation because they have reasons why they might have a poor outcome if they were to catch COVID. And we know that many children are not bothered by the mask. Many parents seem to be. And so why this is very contentious among adults, whereas we've heard certainly from children they forget it on their face. They've still got it on in the car. So I think there's not a one size fits all for everyone. This will certainly leave room for choice for parents. It will also leave many people exposed, including staff, teachers, administrators, and other children. And I'm certainly hopeful and grateful, really, to be in the Bay Area where I'm hoping that for those who do choose to continue to wear the mask, that they can feel absolutely free in doing so. They may do it out of politeness and consideration for others. They may be doing it because of their own concerns for their own personal health risk. They may be doing it because they've got a little brother or sister at home who's under 5 and not eligible for a vaccine, or a grandma or grandpa at home or in their circle who may be at risk of doing poorly if they catch COVID-19. We each have our own individual situations, and I think that we need to continue to do what we can to be respectful of the choices and decisions of those around us. And so I'm very hopeful that within the school settings, that teachers and administrators will be keeping an eye out for this and making sure that everyone feels comfortable with being able to do what it is that they are choosing to do, and not be stigmatized in any way for a decision to continue to do what really is, by all accounts of those of us who are looking at, again, viral transmission. By all accounts, the masking is the safest way to go. And we are still in this evolving pandemic situation. We are not in an endemic situation. And so the last thing I'll say about this masking is that we need to be thinking about, if we get into a situation of higher community transmission, will we need to reenact the mask mandates? And I think these things are very difficult to roll back once you've removed them. But I think that that would be a very reasonable approach, is to be looking at early warning signs, looking at cases going up, and really considering whether at some points we may need to reinstitute masking requirements. So let's just remember that being tired of all this does not equal being done. We are very grateful to see cases coming down, but we also don't have an objective reason at this time to not think that we'll have a summertime surge and a wintertime surge after this. We'll be keeping an eye on the variants, and we'll also be keeping an eye on the impact of removing some of these interventions, such as universal masking within the school settings. And remember that to prevent the most severe and tragic outcomes of SARS-CoV-2, vaccination and booster are still remarkably effective at allowing you to survive in the event that you do catch SARS-CoV-2. And remember that if you are someone who would receive treatment if you caught COVID-19, to please make sure that you know that you have a physician, you know how to reach them, and that you know how you would access treatment if you were to catch SARS-CoV-2. Because again, we are moving into a phase of more of an individual approach. That means everyone needs to look out for themselves. And we need to assume that we are still going to be dealing with this for a while. And so let's make sure we have enough masks, we have enough tests, and we have access to treatment if we're someone who would require it. And remember to eat a balanced diet and get some exercise, some fresh air, manage your stress, take a multivitamin supplement, consider additional vitamin D supplementation, and get a good night's sleep. This concludes today's People's Health Briefing, and we look forward to seeing you again next Tuesday at 10 a.m. See you then.